Good afternoon, everybody. Yep. Hearing okay? Okay. We might get started. So thank you for all coming to join us today. Those of you come from your shift or going on to shifts later on, and we've got some guests who have come in from external to the hospital. So very, very welcome to the Cancer Nurses Day Symposium. Firstly, I'd like to acknowledge the traditional owners of the lands that we meet, the Wurundjeri Woiwurrung people of the Kulin Nation, and pay my respects to elders past and present. My name's Andy Dimmock. I'm the Chief Nursing Officer here at Peter Mac. So I'd like to really start off with acknowledging the contribution for all nurses who provide care and expert delivery of services to all patients, no matter where they are. But in particular today, we're looking at our cancer nurses. So as we know, we deliver care in the home, the ambulatory space, inpatients, perioperative space, acute care and community settings. Just a couple of reflections of myself as a cancer nurse. Two key things really for us really. So number one is our role as a mentor and as a peer for our colleagues, developing and supporting our colleagues as they learn to become a cancer nurse. And those that, as we join together, then we become that strength of a collective group of nurses delivering expert cancer care. But also, really importantly, of course, is the impact we have with our patients, their families, and their carers. So as we know, we look after patients day in and day out, and those interactions we have each and every day stick with our patients. So we forget many times those little times where we're sitting and we're having that conversation, 3 o'clock in the morning, on the weekend, 24 hours a day. You are there and we are there with our patients. And in many ways, remembering where you then sometimes leave the organisation and somebody stops you and says thank you. So it truly is a privileged profession. So really today we're now looking at the Cancer Nursing Society of Australia launching the inaugural Cancer Nurses Day. And we are celebrating 7,500 nurses in terms of their cancer care delivery. The theme is strong, skilled, and specialised. So we've got a lineup of speakers today. The first person is Melanie Menenghetti-Tabone. Our first speaker this afternoon, who has had a career spanning more than a decade in oncology and haematology nursing. Mel developed a passion for oncology nursing in her graduate year at the Royal Melbourne Hospital and went on to complete her graduate certificate in cancer nursing. Mel's career at Peter Mac is marked by her roles in day therapy, where she contributed to as a clinical nurse, ANUM recently classified as a CNS, and currently excelling in her position as an ambulatory care CNC. Today, Mel will be sharing insights in her role and some of the innovative and projects she's led to enhance patient care in ambulatory settings. So please join in welcoming Mel.
Okay, thank you so much, Andy, for the introduction. So as Andy said, my name is Mel. I'm the ambulatory care CNC working primarily through day therapy. And today I'm just going to give a bit of a rundown on what my role entails, because I'm sure a lot of you don't actually know what it does entail, but what I've actually been working on for the last 18 months since I've been in the role. It's hard to believe that I've been a nurse for 10 years this year, and the entirety of my nursing career has pretty much been in oncology and haematology. I'm really excited to be here today to share with you what I've been working on for the last 18 months, and I'm really looking forward to getting some insight into what some of our lovely nurses are doing as well. So as I mentioned, I work primarily within day therapy, and as a part of my CNC role, I act as a liaison between day therapy and Peter Mac at Home. I assist in coordinating care for patients through Peter Mac at Home and through the Day Therapy SCIG program, and work directly with patients to improve their experience of care through day therapy. I also provide education and support to the day therapy team as a whole, including nursing, pharmacy, clerical, and the PSAs, and also work in conjunction with Peter Mac at Home nursing teams. And also have been more recently providing education and support to the ward and medical staff, specifically relating to SCIG, given how much SCIG has grown in the last 18 months. I've also been really fortunate to be a part of project improvement work, which you'll see very shortly. And I think as cancer nurses, we're all very well aware of the increasing pressures, the newly diagnosed patients, the complexity of care, and the increased levels of capacity and pressure within our hospital setting. So many aspects of my role through the work that I do through Peter Mac at Home and SCIG are inadvertently addressing this, which I will show you in the next few slides. So Peter Mac at Home, so through the Better at Home initiative, just to give you a bit of background, there's approximately 120 protocols that have been safe to be given through Peter Mac at Home. The Peter Mac at Home preferred pathway model was created to trigger medical teams and the advanced planning team through day therapy to recognise these pathways and which patients are approved for referrals to this service. So with the introduction of the pathway, it only involved patients who were new to these treatment plans. So in the beginning of my role, I had to manually triage the patients who were already in day therapy and email the medical teams for endorsement. For me, this was pretty time consuming, but I'm really happy to say that it paid off. This data is old data. It's from 2022 and 2023, but it's really representative of a year-to-year comparison for day therapy to Peter Mac at Home and the referrals. In 2022, so in August, there were 16 pathways implemented under the Peter Mac at Home preferred pathway model. And then, as I said, my role was implemented in December. So during that first 6 months, that was my primary goal, looking at referrals and looking at patients who are appropriate for Peter Mac at Home. And as you can see, there was a real significant increase in our data. But obviously, this couldn't be done without the hard work of the education that we did with the medical teams and with the pathways. And we did notice there were some reservations from the medical team in the beginning, but there's obviously been an embracement of that, which is fantastic. And it also couldn't be done without the hard work of the day therapy team and Peter Mac at Home teams working together to get this done. Another real significant part of my role has been in the continued upskilling and education of the day therapy teams, providing in-services, one-on-one education with the advanced planning team, specifically more so the treatment planning team. Oh, sorry. Nope, that's the right slide. As they triage and book all the new treatments and for patients who are referred for treatment. Another thing for me and something that I do where someone isn't able to be spoken to initially, I actually go and see them face-to-face in day therapy and have a conversation with them. So we try and mitigate people being missed for treatment with Peter Mac at Home. SCIG. So SCIG is a really significantly large part of something that I've been doing over the last probably 12 months. And before I get into it, I'm actually going to really shamelessly plug SCIG because I really love it. And there's been a real big increase in the number. So I just wanted to delve a little deeper and just so people have a better understanding of what it is. And hopefully I might get some more referrals. So what is SCIG? So SCIG is a subcutaneous immunoglobulin infusion that's given by slow infusion into the subcut tissue under the skin. It's given weekly or fortnightly by patients or carers or family members at home, and it involves the slow infusion of IG into the subcutaneous tissue. It's associated with more consistent serum IG levels due to the frequent administration and overall reduces the number of infections for patients. So who are our Peter Mac SCIG patients and why? So primarily here at Peter Mac, we generally see patients with primary and secondary deficiencies. And the cohort that we generally see amongst them are multiple myeloma patients, just because of the plasma involvement, CLL patients, non-Hodgkin's lymphoma, post-stem cell transplant and post-CAR T. This is what a SCIG consumable setup looks like. So just to kind of give you an idea, this is what the patients use to infuse every single week. They have their SCIG 60 infuser pump, which is spring loaded and generally takes about an hour to an hour and a half for them to infuse. The day therapy SCIG program is nurse-led, and currently we have 4 RNs rotating in the space, and it operates Tuesdays and Thursdays. And the registered nurses provide education and reviews for the patients. They look after the consumables and the product, and they also triage phone calls from patients on other days. As the CNC, I triage and book all of the IVIG and SCIG patients into day therapy by working closely with the haematology and now neurology teams. This includes me following up the supportive plans, the scripts and the blood start authorizations, which can be a huge nightmare. But now I'm actually looking after over 200 patients in this space. I also oversee the shared care for the regional patients through external providers and coordinate patient travel plans. So when I started in the role, the aim for me was to overhaul the SCIG program and increase our SCIG numbers. So when we first started, we were sitting at 50. The 2 nurses that were looking after SCIG previously did a fantastic job, and it was just time for some fresh eyes and to see kind of what was next. When I first looked at the IVIG and SCIG patients and how they were being referred to day therapy, it was really clear that because of the way that they were being prescribed through our EMR, most of the patients were being referred for IVIG. There was kind of no mention of SCIG, and a lot of the time it came down to a lot of manual emails just from the SCIG nurses asking the question to the medical teams. So instead of reinventing the wheel, I actually proposed that IVIG and SCIG be prescribed on one plan. Kind of makes sense. And they have a distinct question relating to SCIG eligibility, which I copied from the Peter Mac at Home preferred pathway model. Since the implementation of this plan, we've seen a really significant increase in our interest amongst the haematologists for SCIG. There's a lot more openness to talking about SCIG. And it was important to me that all of the patients, regardless of their circumstance, know that there are 2 different options when it comes to immunoglobulin replacement. So it gives me the opportunity to book them and then speak to them on the phone. And then between myself and the SCIG nurses, we pop in and see them in day therapy. It gives us a good chance to show them what the setup looks like. And a lot of the time it's hard to actually explain to them over the phone what it does. And this has made a real significant impact in the uptake of our SCIG. When I first was in the CNC role, I set a really, really high goal for myself and for my SCIG team of reaching 100 SCIG patients by December last year. And now I'm going to show you exactly how that went. So this is a SCIG versus IVIG patient numbers table. As you can see this is from March 2023. So this was about 4 months after I started in my role. Our SCIG versus IVIG was not really comparable. You can see a lot of IVIG patients there. But over the time, we're now hitting June 2024, we're now actually seeing that SCIG is actually taken over IVIG. So as of today, we have 140 SCIG patients and 121 IVIG patients. So to me, that's a really significant milestone for the team as a whole. With the decrease in numbers for IVIG, there's also been an impact to the workflow within day therapy. So in terms of capacity within the transfusion lounge. So what we were seeing was patients obviously having an average chair time of about 4 hours, and that's obviously reduced, now allowing more patients to come in for transfusions, which has been really significant. And I'm hoping that the CNC specifically are feeling that, and it's working well. But it's also really positive for patients overall, because for them, it's about their quality of life, and it means that they don't have to come to day therapy or to Peter Mac as often as what they were before. But yeah, I just wanted to shout out the amazing work of the SCIG team and what we've been able to pull together to make this work. We've also done a significant amount of work in how we upskill and how I train the staff. So there's a lot more consistency in what we do, and on the process of how we educate and review our patients and document that in Epic. One of our SCIG nurses, Alex, is here with us today. She's also helping me look at that and looking at templates and how we can improve our time management, and specifically how we can look at collating some data around reactions, missed doses, infections, GP visits, hospital stays, which for us will also be beneficial when discussing blood start authorizations and with the team as a whole. The next thing I just want to talk about is the Science in Action program. So I've been really lucky to be a part of this program. So I'm the project manager for the Day Therapy Science in Action program, looking at length of stay, specifically for subcut systemic anti-cancer therapies, such as azacitidine, cytarabine, daratumumab, bortezomib, and trastuzumab. We identified a median length of stay for these patients of 68 minutes, which sounds crazy given that it's only a subcut injection. But our aim for our median length of stay by March 2025 is 30 minutes, and I'm feeling really good and that we're going to achieve that sooner than what you think. As a team, we identified what we believe to be the top 5 contributing factors to this significant length of stay, which included drug availability, same-day reviews, same-day bloods, verifying arrival processes, and pre-medications in the chair. And this led us to our PDSAs, which meant that we needed to implement 1, 2, and 3 to effectively impact our length of stay. So as it stands at the moment, we're currently at our PDSA 1, which I'll go into in a sec. Despite most of us thinking that the problem was the drug not being ready, we were surprisingly shocked that it wasn't the drug that wasn't ready. It was actually the process before that. So what we found was that 92% of all subcut drugs were made in advance, but only 61% were actually coming out before the patient's appointment time, and the rest afterwards. And why that's important is that unless a clinical check is done by a nurse and a pharmacist, that drug cannot be released from CytoSuite. So what we needed to do was look at the day prior checks and come up with a system to make that work. So this is our first PDSA, which was to trial the prioritisation of the subcut charts checked by nursing and pharmacy. This only commenced on July the 9th, and there's been a real improvement significantly with the percentage of both charts going from a baseline median of 33% to 78%. And that happened pretty quickly, and we've also been able to maintain that as well, which is very exciting. Some things to note, some days we were sitting at 100%, and then other days we weren't, and that was due to patients who were coming in to have same-day reviews and same-day bloods. But it also highlighted an area of opportunity for us to strive for a 2-day treatment model to get to a target of 100%. Given that our consistency has been there, we're looking at moving on to our next PDSA, which is bulk releasing of subcuts from CytoSuite, which means they'll be released in the morning, so the treatments will be there ready to go when the patient arrives, and also patient self-administering treatment, their pre-meds before treatment, which will also heavily impact the time that they're in the chair. Just quickly, some other things that I've been involved in over the time. I was lucky enough to submit an abstract and present at CNSA conference in June last year and the HIF conference. I've also been involved in the Blood Matters GIG forum last year, and also a part of the new Optimal project through Monash Health with Thanks Hayley, redesigning IG service delivery, and also looking at supportive subcut medications and a working group in that space. So what's next for me? So I guess for me, it's just a continuation of support and coordination between Day Therapy and Peter Mac at Home, and continuing to grow and implement changes within our SCIG program, and continue to challenge the way that we do things and implement change through project work, working alongside Sandy, with Mish, with Vikas and Fiona. But I think it's really important to note, like, there's plenty of work to be done to integrate and utilise and bring together ambulatory services as a whole. And I'm really looking forward to reaching those goals in the near future. Thank you.
Thanks, Mel. That was really impressive and great to hear about. So next up, we're going to hear from Joey, who is a very dedicated cancer nurse, currently working as an ANUM in specialist clinics and outpatient pathology. Joey's journey into oncology began about 8 years ago when she moved here to Peter Mac, and she'd been previously working in the critical care environment overseas. She's passionately committed to the oncology field ever since, and I'm looking forward to hearing about her insights. Welcome, Joey.
Thanks, Kyra. And hello, everyone. Sorry if I'm having a coughing fit. I've just been attacked by the Melbourne's pollen this week. My topic is going to be a bit of a light topic, and I'm kind of inviting you into a bit of my life, even though if you didn't ask for it. Like Kyra said, I was an intensive ICU nurse for a while, and then I became an oncology nurse 8 years ago. And I was just going to summarize into 3 reasons why I'm passionate in cancer care, even though there's a lot of reasons behind it. Just a little bit about me. I was actually born and raised in Malaysia, so English is not my first language. If you kind of feel like I keep repeating myself, that's because I'm really nervous. So like I say, I've been in Peter Mac for 8 years now. I've started as a registered nurse in Ward 3A in the old hospital. Ward 3A here. It was a medical surgical ward at that time, and then slowly it became a medical oncology ward. And then after 3 years of being an RN there, I've credentialed to be a CNS, and slowly after that, an ANUM. And just last year, June, I've decided to just venture out to join outpatient setting, and now I'm in one of the ANUMs at outpatient pathology and specialist clinics. Just a little bit about my nursing journey. So in the last year of my high school, I've applied to an exchange student program. So it landed me to Texas, USA, very far away for my last year of high school. And in the last semester, they have a very interesting program which they invite the senior students to shadow someone they would like to be in the future to see if they actually want to be in that occupation. And my parents always wanted me to be a doctor. So I've applied to shadow a doctor, but it was such a short notice, they can only give me to shadow a pediatric ICU nurse, which actually is a blessing in disguise, because then I found my passion. I felt like I can't do anything else. I have to be a nurse. So after high school, I applied to a nursing school in Virginia and got in. So that is the first picture. There's me with my fellow classmates. It was in our sophomore year. We were, that's second year of nursing school, and we were practicing on each other, giving each other IM injection. I shared this with Amu yesterday. She said that it was pretty much illegal in Australia, but I promise you, we were injecting normal saline to each other, nothing else. So in America, you have to do 4 years of nursing. So after that, you get your Bachelor of Science in Nursing. And then is the gruesome test of NCLEX. I don't know if you ever heard of NCLEX. Is pretty much, it can be a 78 questions to 120 questions. It's multiple choice, depends on how well you do in the test. So it consists of 4 years of nursing knowledge in the test. It's 2 hours, and then you can be cut off at the 78 questions if you're doing really well and they pass you straight away, or you're doing really, really bad, they just fail you. Or if they can't decide if you can pass or not, they will just keep giving you questions until the 120 questions. And they didn't shut me off at 78, so I kept going, and they kept throwing me pediatric questions. So I know I wasn't doing really well in the pediatric nursing field, and they cut me off at around 100 questions. And they won't let you know if you pass or not. You have to wait for 3 days. And usually around this time, you already have a dream job lined up. Depends on if you pass NCLEX or not. But long story short, I passed NCLEX, and I landed at my dream job, which is my first nursing job in a neuro ICU at University of Virginia, which is a level 1 trauma center. It was pretty intense. Even though we have 4 years of nursing training, and my last year I was actually trained as an ICU nurse, it's still pretty intense because the patient ratio is actually not as great in the States. So if you're an ICU nurse, you're actually taking care of 2 intubated patients at a time. Sometimes even if you have a not really sick patient, you will have a combination of a patient where they're essentially brain dead and you're keeping their organs alive. And that's really tough, but it's such a privilege to be in the care of heroes that are going to save a lot of lives. I had to learn really quickly but I was mentored by really wonderful team that I met there. And yeah, I had a great time in ICU. I felt like it have shaped me to who I am now, that I usually can be calm in situation that's really just chaotic, and be able to make clear, decisive decisions around patient care. After 2 years of really just adrenaline-filled journey, I decided to pack my bags up and leave America, live my dream job. And if you wonder if it's because of love, it is. I met my person. He was also working in the States at that time, but he was also from Malaysia. And when we decided to get married, we decided to move somewhere closer. And he got into University of Melbourne for his Master in Engineer. So we came here. We knew no one. We don't have any friends here, but we got each other. That's what matters, hey. So just a bit of a transition when I came over to be a nurse. I get to just change all my license. It's just paperwork. It was pretty easy, but knowing where I want to work is hard, because I remember my very first shift, people were asking me to get Tarjan. I was like, what is Tarjan? But I didn't want to ask anyone because I felt like I would sound dumb, but we never use Tarjan in USA, but it turns out it's just pain medication. So I joined agency nursing. They sent me to different hospitals in Victoria and Melbourne, and mainly in ICU to start out with, and then ED, as well as some step down units. But I really was missing some kind of interaction and connection. One, my patients usually asleep or in a coma. No one's talking back to me. And it's hard to make friends with the team as well when you're in agency, because you're not there regularly. But my life changed ever since my first shift in Peter Mac. And I remember the first shift was in acute AAA. So that's acute assessment area in the old hospital, if you ever worked there. The nurses there, like every nurse, don't get me wrong, they all very kind and passionate. You gotta be like that to be a nurse. But Peter Mac nurse is up level. I felt like it's because of all the patients that they have to deal with day in, day out. The nurses that actually care about why I came to Australia, show me where the best coffee is. My patient talks to me. They're really nice. And I remember that very first, so I kept asking the agency to send me back to Peter Mac, and they did, thankfully, even though I have a little bit of oncology background. And I remember the shift that I decided that I want to join Peter Mac is in Ward 9, which was the medical oncology ward. And they invited me to sing a Happy Last Chemo Day song to a patient that finished his chemo. And this song rhymed with happy birthday. It's just happy last chemo day. It's a bit cringy, but at the end of the patient is a teenager. He gave a little bit of speech, and he mentions all of the names of his nurses as though it was more than nurses. It was like friends. And at that moment, I felt like I want to be a part of it. So I applied. And my very first day here was the first week we moved here to this new hospital. And I remember I ran into the lift, and then I couldn't find a button to go to level 3. I was really scared, but it was just a fancy hospital. Which brings me to my very first reason why I'm passionate about cancer nursing, is to build a strong connections. Not that I don't build strong connections with my patients in my previous job, but in cancer care is very different. The continuity of care in cancer treatment means you get to know your patients and their families pretty well. And the picture right there, I have a star on her face because I can't ask permission actually. She was my very first patient in 3A where I was almost going to be competent to give chemo. So I was involved in her care from the beginning till the end. She was only 16 at that time. I remember I gave her first chemo education. I didn't know much how to do it. I was just reading off a script, and she was only 16. She careless. She wanted to just get it done over with. But as soon as we touch about losing hair, you can just see she started to cry. She has this most gorgeous orange long hair that you ever seen. It's kind of reminding you of the Disney character Brave. So hair was really important for her. But weirdly, we bonded over that. There's no TikTok at that time, but we went on Instagram, we checked on alternatives and how we can do things differently if she does lose her hair. She did lose her hair, it's 2 cycles in. But it's just a journey to get her through it. And I also remember those nights where she was admitted, not because of chemo, but because of chemo-induced mucositis. That was really bad nights for her. She couldn't take anything except for the lemonade popsicles that we had. Some nights shift that I'm not busy, I will sit with her and have the popsicles together and we talk about schools or boys, like we are friends. It's really weird. And then come the day where it was her last cycle of chemo, we get to sing the happy last chemo day. That really meant something to me. I remember I have to run out of the room because I couldn't stop crying. And her mom came out and gave me the biggest hug ever, like I was one of her own. That was the moment where I felt like I'm gonna stay in cancer nursing. And then this picture is taken after 2 years of her last chemo. She came back to talk to us and to share about her journey. Now she's in culinary school. She's gonna be a chef. She's doing really well. And not just patients and their families, I built really strong connections with my team. So this is just part of my team on a Christmas Day on 3A. It's just a different kind of friendship because you kind of bonded over traumas, kind of. So you always can take one look in each other's eyes and they know exactly what to do. They will bring you a cup of tea or take your call bells or your phones away so that you can have 5 minutes of silence. Or I always joke with Amu, if I press my patient's call bell, I look at her, she knows exactly how many blueies, pull-ups, and wipes I need. Like she will come in with all of that. So I felt like there was something that I really treasured. It's the friendship that and connection I've built in cancer nursing. And then next reason is cancer care really humbles me. Our patient literally lives with uncertainties from prognosis to treatment outcomes. And because of this special connection we have with them, you kind of live through all these journeys with them. It's like a roller coaster. It taught me to learn how to acceptance of the illness itself, and also acceptance of the treatment outcomes, but even the acceptance of limitations from medicines. I remember this patient that was from China, so we share a similar background, similar age, and we went through the chemo cycles. We had the last day, hug each other and hope that we won't see each other again. Came back a couple months later with chemotoxicity, where conditions so bad that it took away her healthy beating heart. That was the darkest memories I had in cancer nursing. But throughout my healing process, I realized that cancer nurses actually play a very important role to help patients to help patients and families to come through to the realities, to face the realities, finding peace and meaning even in the face of death. And this is such a privilege. I felt like it's such a humbling experience, and it's also helped me to become a better person as well. The last but not least reason is the opportunity to learn and grow in this field. Cancer nursing is a field that demands us to continue to develop professional development and learning, just like what Mel was sharing. Ski, how awesome is that? And I always joke about this, but I felt like I have a dream. I wish that one day we don't have chemotherapy anymore. Hopefully our immune system will be able to fight cancer. It's just an ever-changing treatment and the very exciting, groundbreaking trials that's coming out at the moment. And to be a part of it was really great. Also, I also get to do a lot of different stuff outside of nursing as well. I joined the EMR team in 2020 to introduce Epic to our fellow colleague to become an EMR trainer. That sparks a little bit of joy in me because I'm into digital health as well. So yeah, I've been learning that a lot. Yeah, so that's it kind of my presentation. But what I want to say is I'm glad that oncology nursing chose me and that I get to be a part of this special team. And I certainly can't do any of this without all these colleagues that I met here. Cool.
Thank you so much, Joey. That's really, really beautiful and resonates with many of us in this room, I'm sure. So now I'd like to introduce our next speaker. Priscilla is a research fellow in Health Services Research Department at Peter Mac and was recently awarded a Mac Future Leaders in Health Services Research Fellowship. She is also the recipient of an Executive Dean Health Research Postdoctoral Fellowship at Deakin University. Priscilla has been a cancer nurse for 30 years and was first appointed CNC at Peter Mac. Today, Priscilla will be reflecting on her cancer nursing career and focusing on her opportunities as a clinician researcher. So please join me in welcoming Priscilla as she presents on cancer-related cognitive impairment. It's all in your head.
Firstly, thank you, Andy, for the introduction and the opportunity to share the inaugural Cancer Nurses celebration with you all today. I too, like Andy and the previous speakers, really feel that I have had a privileged career. As Andy said, my career spans 30 years now as a cancer nurse, and 22 years of that have been here at Peter Mac. So I've really seen the growth of advanced practice nursing roles here at Peter Mac. I've worked across its 3 organisations and seen huge growth, and those 2 previous speakers that we just witnessed are a real, clear illustration of that. I've had a lot of opportunities that were created as advanced practice roles, became, very popular in cancer settings. A lot of these opportunities were created by fellow nursing colleagues, and I'd like to just share a few of them with you today. So as Andy said, I think my biggest claim to fame, but shows my age, is I was the first CNC at Peter Mac. It was back in 1996, and it was an autologous bone marrow transplant coordinator in the haematology service. This opportunity was really created firstly by a gap in service seen by a medical colleague, Professor Miles Prince, who wanted to develop bone marrow transplant service here at Peter Mac. But he came from the Toronto General Hospital in Canada, and he was like, we cannot run a bone marrow transplant service without a senior nurse to coordinate the service and improve outcomes for patients, carers and family members undergoing transplantation. It was also greatly supported by the Director of Nursing at the time, but also at the Nurse Unit Manager of the Haematology Unit, which was Linda Clark, who still works here at Peter Mac today. So I was sort of instrumental in developing other advanced practice roles across Peter Mac at that time, and now we, clearly know how many advanced practice roles and CNCs we have in every clinical service across Peter Mac. And it's something that, I'm very proud of, sitting next to people like Donna Milne here today. We've really grown up, through Peter Mac through the years. So my clinical experience as a haematology nurse, like, Mel sort of talked about earlier, we get many clinical questions in our daily practice. And one of the questions that was coming up on a daily basis is, how do patients who have got a life-changing diagnosis and undergo bone marrow transplantation then pick up their lives and move on after that happy birthday, you finished your chemotherapy song? So I really developed interest in survivorship care and how to better support people after they'd finished, their very arduous toxic treatment of a haematological malignancy. So once again, with support, I was able to gain external funding to develop the Haematology Late Effects Clinic, which was under the umbrella of the Late Effects Clinic, which aligned with National Igaronsi being the CNC there. But this was very much supported by John Seymour and David Ritchie to develop a haematology-specific clinic. So I was the CNC in that clinic, and once again, so many clinical questions coming up, and I was given the opportunity to do a Masters of Philosophy at Melbourne Uni, supervised by Maya Krishnasamy, and that developed nurse-led survivorship interventions for survivors of Hodgkin lymphoma specifically. To really grow on my knowledge in survivorship and probably my passion, I work collaboratively with the Australian Cancer Survivorship Centre to really learn about developing models of care to support people post-treatment for cancer, and also really implementing nurse-led models of care across the organisation. So in 2004, I was given the opportunity to go to the new ONJ Centre at the Austin, really to develop survivorship care in haematology there. I was the autograph BMT coordinator and was able to develop a nurse-led survivorship clinic. And once again, in my clinical practice, patients were coming to this clinic all the time saying, I can't return to work. I can't return in the same capacity because I can't remember things. I can't remember people's names. I wouldn't be able to run a meeting. And as a clinician, there's not many sort of areas of cancer care now that we don't know the answers to. So you'd sit there in a nurse-led service thinking, I don't know what caused it. I don't know if it was the cancer itself or the chemotherapy or your immunotherapy or your novel therapies or your bone marrow transplant. I don't know when it occurred within that treatment trajectory. I don't know when it's going to go away, but most importantly, I don't know how to advise to support you to do this. And I found that really difficult, that we didn't have answers. So I was given the opportunity with a Victorian Cancer Agency PhD supportive care scholarship, and I undertook my PhD, which I'll just go through briefly with you in a few more slides. And once again, I still had the strong collaboration with Peter Mac, being supervised by Maya Krishnasamy. So now I am doing a postdoctoral role, which is still informed by my clinical practice and my clinical questions, which I will share with you. And I'm very blessed to have my collaborations with Peter Mac by having a research fellow role in the Health Services Research Department, and excited about recently being appointed a Mac Health Services Research Future Leader Fellowship. So you all know in the room here that cancer-related cognitive impairment is very distressing and disabling for most people undergoing treatment for cancer. It's documented literature that up to 70% of people with solid tumours experience these problems. Like I said, for some it may be transient, but for others it may be long-standing, impacting ability to return to work, the quality of life and their ability to function. However, there's limited knowledge. Most of these studies to date have been done in breast cancer. There's limited knowledge in hematological malignancies and many other solid tumours. And as I said, we don't know anything about the causing, the timing, or therapeutic options, or how to support people experiencing it. So my research findings has informed my nursing clinical practice, have shown that for the first time that it is feasible to complete a longitudinal comprehensive assessment of cognitive outcomes over the course of treatment and recovery for people with newly diagnosed lymphoma. And we demonstrated that is a real problem for these people. And as a nurse, we had very comprehensive subjective and objective measures. The people completed subjective measures, but I was also trained to undertake neuropsychological testing, where the participants on the study underwent 6 validated measures that are recommended by the International Cognition and Cancer Task Force. So I was doing the neuropsych testing, and I continue to do so in my current study. So an amazing opportunity for a nurse to learn that skill set. We also did neuroimaging. So we did PET acquisition scans of their brain and MRI images in my current postdoctoral role and in the cognitive neuroscience at unit at Deakin, I'm learning so much about neuroimaging, something I thought I would never really grasp. But it's amazing when you're embedded in that field amongst, once again, multidisciplinary clinicians who are so willing to share their knowledge. So another real privilege. And we also looked at the role of inflammation on cognition, and I'm working with neuropsychiatrist in Sydney, Adam Walker, who has presented here at Peter Mac before, looking at the role of inflammation on cognition. So it was interesting that despite the distressing, challenging and stressful nature of a new diagnosis of lymphoma, our recruitment and retention and completion of study assessments exceeded all of our expectations. It really shone the light on a nurse as a clinician researcher, that the clinical team valued the study. They wanted to learn more about it and how better to support their patients. And also patients really appreciated that finally someone was talking to them about their memory and thinking and how it was impacted, because they began to think they were anxious, they were depressed. It's not important because it's more important what my full blood examination says and what my lymphoma is doing. So we also undertook a qualitative sub-study to understand participants' motivation to participate in this study and the reasons for sustained participation at such a time of heightened stress related to a new diagnosis. So this is a busy slide, but I'm just going to tell you that part of my PhD, we looked at the 30 people in my study with newly diagnosed aggressive lymphoma and compared them to 72 healthy controls. What this showed on subjective measuring using the FACT-COG, that the participants experienced significantly worse impact on their perceived cognitive impairment on quality of life before chemotherapy started and at 8 weeks post-treatment completion. Similarly, on neuropsych testing, on the objective measuring, they performed significantly worse for executive functioning, verbal learning and memory, attention working and memory than the healthy controls before chemotherapy started and 8 weeks post-treatment completion. So as nurses and clinicians, we've really shown that we have provided evidence of impaired cognitive functioning in these people. And it's consistent with emerging evidence that cognition is impacted before chemotherapy or before treatment even starts. And we need to use the words cancer-related cognitive impairment instead of chemo brain, or cancer brain is more appropriate for future research. As nurses, it's important that we screen for cognitive symptoms and we have clinical interventions that we can support patients with during and after treatment. And once again, as nurses, we need to prepare people for these potential cognitive changes and give them simple strategies to manage, which would be a step care pathway in normalising these changes and the emotional distress associated with it. So it's clear that there was a need for larger longitudinal studies to inform the development of targeted interventions and identify the best time in the treatment trajectory to implement them. So my current postdoc study, which I'm really excited about because it hopefully will identify an intervention that will support people experiencing these problems. So it's a web-based cognitive rehab program called Responding to Cognitive Concerns, or eRECOG, and it's for people self-reporting cognitive changes following chemotherapy for aggressive lymphoma, and it's a pilot RCT. This study, I'm pleased to say, we recruited our 38 people within 10 months and completed data collection last week. All our recruitment was done through the haematology service here at Peter Mac. Once again, shining the light on clinician researchers and particularly a nurse researcher, that the clinical team value the study. They know you, they know your history, we've all grown up together, and they value the study, but more importantly, the patients value the study. They trust you and they have the unmet need. So our compliance also was excellent. I'm very grateful for the haematology service, in particular Michael Dickinson and Tracy Dryden, who's in the room over there, who really helped with identifying participants and recruiting, assisting with recruitment. Without them, this wouldn't have been possible. So Responding to Cognitive Concerns is a web-based program that offers adult cancer survivors psychoeducation on cognitive dysfunctioning, and it's based on the principles of CBT. They receive one module per week in this study, Each module takes about 60 minutes to complete, and they do it in their own time in their own home. So participants were either randomised after their neuropsych testing and their self-report to either receive the cognitive rehab intervention or usual care, and then they underwent the same assessments at the same time point. The modules address ageing, health, cancer and cognition, memory, attention, and also importantly, symptoms that quite often run in parallel, being fatigue and emotional distress. And this is just a quick snapshot of one of the modules look like. So I'll finish with my acknowledgement. I will reiterate that I think I've illustrated here that I have had a very privileged cancer nursing career. I wouldn't change my my career choice at all. It's been amazing, and hearing Joey talk about these patient experiences, people like Donna and I, and Kerry, Tracy, we over the decades have many of those patients' stories that have informed this work. But most importantly, thank you to the clinical services, the health services research department here at Peter Mac, the cognitive science unit, and in particular the participants who so kindly give up their very precious time to support this work and inform it. So thank you.
Thanks, Priscilla. That was amazing, and I'm looking forward to the next update on your work. Next up, we have Angela Prestigar. We're hearing from Angela today, who's dedicated 16 years of her nursing career to oncology. She started out with a passion for oncology nursing at the Beatson Oncology Centre in Glasgow. Upon moving to Australia, she joined us at Peter Mac. At Peter Mac, she has excelled in her roles as an ANUM educator and plays a pivotal role in the training and education support of our next generation of cancer nurses. Please welcome her as she talks to us about carer-led hydration in the home.
Yeah. Thank you everyone for letting me come and speak today. Hopefully I speak slow enough for you to understand me. So thank you, Cara. I am one of the PDNs at Peter Mac at Home, and I'm very lucky that I was able to go into that role in 2022. It's been a privilege to be there as well. So I am going to discuss the topic of carer-led hydration in the home. This was a new programme developed by our department for patients who required long-term hydration at home. So I'm just going to go through the key principles of what Peter Mac at Home is, the patient story, and I have got permission from our patient who is on the programme currently to discuss this today with you guys. And also why we implemented the new policy and procedure. It was actually the first policy that we could actually find in Australia. And also we couldn't find much in the UK either, so very exciting, and some patient feedback. So these are our golden girls, oh sorry, here we go, from the 1950s. These were the original Peter Mac at Home nurses with their driving gloves. And lovely comms came down yesterday to try and do a reenactment of some of our current team on Flemington Road. So we have a great team of nurses. I'll just run through who we've got in the department. So as I said, it has been around since the 1950s. We were originally called the Visiting Nursing Service. And we used to only visit patients 20 kilometres from the original hospital at Peter Mac. We are now called Peter Mac at Home, which we visit a lot of different patients. We have two systems from the Department of Health called HIF and non-HIF patients. HIF patients primarily would be your vac dressing, drain tubes, IV medication, including a lot of systemic anti-cancer treatments, and non-HIF patients, which are really radiotherapy dressings, Plurex, Peritex, CVAD care, and cross matches. So we now have a boundary up to 45 kilometres northwest and 20 kilometres southeast in Melbourne. Patients beyond our boundary are outsourced to regional nurses, and we've got two nurses within the department, CLNs they're called, and they'll do our referrals for us. We operate 7 days a week from 7 till 7 o'clock at night, and we've got 4 shift times from 7, 8, 9:30 and 10:30. We've got 37 road staff, 14 cars, 7 ANUMs, 2 PDNs, which is myself and Yasmin, who does point 2. Our lovely Num Mish, we've got our 2 CLNs who are allocated Monday to Friday, 1 HMO, and we also have 3 admin staff. I felt bad leaving them off here because we'd all collapse without our admin staff, wouldn't we? So I just wanted to discuss Marie's story. So lovely Marie is a 71-year-old female with ovarian CA. In 2014, she had cytoreductive surgery and a resection, a rectal sigmoid resection. Unfortunately, in 2022, she had some complications with a malignant small bowel obstruction and had to have an laparotomy, and she had a stoma formation at this time. So one of the complications, unfortunately, from her surgery was that she developed short gut syndrome. For anyone who's not familiar with short gut syndrome, it is a malabsorption disorder that's caused by lack of function of the small intestine. The body does not absorb or digest the food normally because of the large length of the intestine is missing or not functioning. So some of the primary symptoms we do have is diarrhea, which can result in malnutrition, weight loss, electrolyte disturbances. And in Marie's case, unfortunately, she was having high outputs from her stoma bag on the ward. And from that, she was having to have an electrolyte and also IV fluid replacement as an inpatient. So she needed to have this ongoing and lifelong at home for Marie. So Marie was admitted to Peter Mac at Home, our HIF programme, in September 2020, requiring a litre of fluid daily to be administered. And this was around an hour and a half visit every day for the nurses to go and see her at home. And also she had a little bit longer on the days that she needed her CFAD dressings done as well. So you can imagine this was quite time training for Marie as well, relying on us to go every day for her, which was a bother, but yeah, very hard. So from here, how we developed the programme is Marie actually approached Peter Mac at Home at the end of 2021. And she actually asked if her and her husband could be taught to give the fluids at home. So from here, we had a discussion with our NUM, our operations director at the time, and the patient's consultant, which they all agreed to move forward with the programme. So we did an extensive search for policies and procedures and other HIF organisations around Australia and the UK, and we did not find anything for intravenous fluid, especially through a CVAD at home. There is some policies for IV antibiotics in the UK, short pushes and not long term. So from here, we got involvement from our infectious disease team and infection prevention, our chief nursing officer, our medical lead, operations director, and pharmacy, as well as ANU support to go through this process. So I arrived in 2022 and I helped develop a few of the policies and programmes to allow this to happen at home. So from here, we developed a carer self-learning package for patients to receive the long-term hydration at home, which is quite an extensive procedure. A new hospital-wide policy and procedure for Peter Mac, including the checklist to ensure that the carer was able to comply with our policy. And then we also had to get legal involved because we were allowing the carer to take over ownership of that. So there was quite a lot of legal components to allow a self-declaration. We still took ownership of care because we still wanted medical oversight, so we would still be contacting the patient daily. And then an extensive training programme. So our training programme and requirements, so we also needed some kind of criteria for patients to be on the programme. So they needed to have fluids for longer than 3 months. There was no point in training someone for a month and then they go off the programme the next week. So obviously, as I said, the patient and carer needed to sign a valid self-declaration to go on the programme. The patient needed a central venous access device, preferably a PICC or a Hickman, to be on the programme. And the face-to-face training entailed 28 days of daily visits or equivalent of months training if they were not receiving fluids every single day. The RN checklist, which we created, was basically from start to finish on the procedure and basically focus on our aseptic technique. And you have to remember the carer in this instance, Marie's husband's a painter and decorator. He's got no medical background, so we had to train him from start. And he did it very, very well, but obviously a foreign procedure to him. So obviously he had to learn all about CVAD care, accessing, de-accessing, monitoring for signs and symptoms of infection, and troubleshooting in the home. Obviously simple things that we would do as nurses straight away, learning how to prime a line, also key parts and key sites, connecting and disconnecting the IV line, PPE and disposing of the waste appropriately. So also on top of that, the carer did learn how to take some vital signs as well. Some of the criteria being on the programme, the carer also had to inform us if he was unwell at the day, so we would go and visit the patient instead to give the fluids. Also, we did make the carer and patient complete the National Hand Hygiene Institute module. They have to do it every 6 months as per of our infection prevention team, fair enough. And they did do that, and they've been very compliant. And on top of that, so just to have that oversight, we do telehealth with the patient, and that's the ANM that will run that on the shift. We just review the vital signs, observe the PIC length to make sure there's no changes from the last CVAD picture. They do complete a full standard assessment on the phone as well and document that on Epic. When we do the home visits every week, because we have to do our CVAD dressing still at home, the RM would do then a reassessment of just the patient's carer connecting to the line. And we would pick up the patient's daily checklist as well, because they have to check off what they've done at home, and we'd scan that all into Epic the next week. So that's just, sorry, a wee screenshot of the RN checklist there. That is on Epic. So it is a bit longer, but I didn't want to add 10 slides to the slides I had. And that's the patient checklist as well. So obviously there is some criteria for the patient and carer. We don't expect them, if they feel they have to change or they don't want to continue on with the programme, they have the option to revert back. So it's quite clear in our self-declaration that they can opt to go back to Peter Mac at home at any time. As I've said, the daily checklist, that is part of our KPIs, that is scanned back to Epic, and also the RN weekly checklist as well, that's scanned back to Epic. If the patient does develop a line infection, they are reverted back to face-to-face training, and retraining is required to be on the programme. From this, our patient obviously has improved quality of life and does not need to rely on daily home visits every single day from Peter Mac at home. And as well as that, the patient can go on vacation on weekends and the weekdays that she doesn't have to see us as well, which is a really great programme for her. So overall process, it did take about 1.5 years to develop this programme. Multiple reviews from key stakeholders, our Chief Nursing Officer, ANU, Competency Review Group, Legal, Medical, Infection Prevention and Infectious Diseases. And then we had to present this back to PPRG, which did have a separate consumer to review all the procedures and policies. On top of that, we did have to get a literacy review with the Health Literacy Age to make sure our handouts were targeting the patient appropriately for any patient coming onto the programme as well. We also allowed Marie and her husband to read over the material, as they were obviously doing it every single day, just to make sure we were tailoring it correctly also. And the pictures within are Marie and her husband, so you will see them online as well, and she's consented to all that being online. So we've been up and running for about 18 months now. Current cost savings, although we didn't do it for cost, we have saved $35,000 by doing this in the last year. It's obviously improved patient-centred care. We did currently have 3 patients eligible for the programme. One sadly passed away, but the other 2 have opted just for the home visit, and they're not having it daily, they're just having it twice weekly. They prefer to see the nurse, which is fair enough. And I just thought I'd do a wee bit of patient feedback. So lovely Marie, so I asked her before the programme how it was for her. She said it was very difficult being stuck in all day, not knowing what time my visit would be until that day. And I could not make any plans until my visit was completed. I felt it was very time limiting for me. After the programme, she said, I have so much more freedom. It's a fantastic service. I don't have to wait in all day for my visit, and I can go away on the weekends to see my family and friends. I am so grateful, and I'm aware that Peter Mac at Home nursing team is there if I need it. They are the best nurses in the world. And I thought I'd just pop on our resources. Obviously our policy is up on the internet, and obviously the intravenous resource and declaration as well, with all the contents. And some acknowledgements. I would like to acknowledge the Royal Children's, because they do have an antibiotic policy that did help shape our programme for home. We did develop this on our own from Peter Mac Home, but we did have really good support from our medical lead, NUM and CNO, and obviously Nikki Dean, who was our clinical nurse educator at the time, gave a lot of feedback and support. So thank you.
Donna, thank you, Ange. That was great. Donna, our last speaker of the day, and sorry everyone, we are running over time, but it's been very exciting listening to everyone. Donna, our final speaker, was honoured earlier this year with the Chief Nurses Award at the first Peter Mac Nurses Award. She wasn't here to accept it at that time, but I have talked her into speaking to us today. She has a distinguished career working in cancer care for 22 years, and her commitment and passion for nursing makes her a revered mentor and role model in the field. I'm eager to hear what insights she has for us, and what her cancer nursing career has taught her. Thanks, Donna.
Thank you. Thank you, Kyra, for that very humbling introduction. But I have to say, you know you're getting old when somebody asks you to reflect on your career. So thanks a million for that, Kyra. Happy Nurses Day, everybody. And I think it's what a wonderful occasion it is to be able to come together like this to reflect on and to celebrate what we do so well and in such a skilled way all day, every day. So congratulations to you all for what you do. Things have changed a hell of a lot since I walked through the door of the nurses' home at St Vincent's Hospital on August 2nd, 1982. So much so that the nurses' home has now been knocked down. It's not even there to walk into. And I'm constantly reminded by my younger colleagues that they weren't even born when I started my nursing career. So that's a lovely constant reminder as well. So I think when I was asked to do this, I sort of wanted, I don't want to go back and say, in my day, we did this, or it was better when we did that. But instead, I wanted to sort of reflect a little bit on the changes and some of the similarities that I've seen over the years when I have been working. I started my cancer nursing career at St Vincent's and then ended up here. And there has been a lot happen. So, things that spring to mind, first of all, was when I was a first registered nurse, there were no nursing ratios on the ward. That's been a massive change. There was nothing for us to be a first year graduate looking after 8 patients on a ward, post-op or med-onc or whatever, or medical, whatever it may be. And, I remember being in charge, I think I was probably second year out, in charge of the medical ward, when I was, 20 or, 22 or something. And so we have come a long way in terms of our professional development and patient safety and our safety, which I'm very thankful for, because some of those days were a little bit hairy, I have to say. New drugs, I've been very lucky to experience the advent of new drugs, and in my area, particularly immunotherapy. And I'll never forget Grant MacArthur saying, probably back in about 2013, when we first started using ipilimumab, that this is like a penicillin moment in medicine. And to be at the coalface and for us dealing with that and the patients and learning as we went along with each other was quite a privileged position to be in. And I think privileged is a really interesting word that we've heard from just about every speaker this morning, and I'm going to speak a little bit more about that as well. Computer systems, EMRs, we would write in, the patient histories, and you'd have to get them from medical records and take them places. And then, you'd go to medical records. Where's this record? Well, it hasn't been returned from clinic 2. So, we haven't got it. So, that sort of thing is an amazing change. But, one of the things that also has been fantastic is watching as our profession has grown to become a skilled and professional workforce that is recognised, as just as that, but also recognised, I think, as we're recognised now as a key member of our multidisciplinary team. And that hasn't always been the case. And, I totally understand that in some areas there's a little way to go. But I'm very thankful that in the environment I work in, our nursing roles are highly valued and recognised, and our opinions are sought. And that's a really great development. So there's just a couple of other areas of cancer nursing that I'd like to share with you. And the first one is around cancer nursing providing opportunities and career pathways. And, we've already heard 3 different nurses that have talked about 3 very different areas that they work in, that they are very passionate about, that, have changed what they do and the care of our patients. But, we've got opportunities to become specialist in a particular cancer type, like whether you're a CNC or whether you're a nurse practitioner, or in a treatment modality like CAR T-cell therapy. And, with immunotherapy, that's been an area that I've been able to focus on. And then it won't be long before we've got TILs on our doorstep, and that's going to promote open a whole lot of new doors for people to learn about. I think about surgical oncology and prehab. I never knew about that back in the day. As I've just said, I'm not going to talk about back in the day, but just, you know what I mean? Like that's a really new thing. Preventing complications post-op is so much more in our mind as opposed to dealing with complications post-op. We're preventing them. And I think about the way nurses are positioned to support patients living with their new normal. And in particular, I think of my stomal therapy colleagues sitting here, the work that they do day in and day out, helping patients adjust to a new body image, adjust to having a stoma or 2 or 3. That's amazing work that is unique to and a very privileged position for them to be in as well. RADONC, management of acute toxicities and helping patients to learn how to self-manage these at home. Even thinking about cancer as a chronic illness now, that's a huge shift for us to think. When I first started in melanoma in 2010, I think it was, patients with stage 4 disease had an average life expectancy of 9 months. We gave them DTIC, temozolomide, and referred them to palliative care. Full stop. Now we've got more treatment options than we can ever imagine. It's hard to explain all the options to patients, but I'm now seeing patients that are coming back 10 plus years down the track, but they're living with the outcome of their treatment. So they've lived, but they're also having to deal with, often chronic sort of conditions that has become their new normal. Maybe you want the opportunity to educate others, whether it's our patients or whether it's our other staff, so that we keep safe, so that we're safe, we keep our patients safe, and we keep up to date. Like Priscilla, you might want to be involved in conducting research and doing, new things that are always working towards making things better for our patients. Or you might work in clinical trials, another way of being involved in research. And there's plenty of other things that I haven't listed, but I hope that gives you a bit of an overview of where I'm coming from. And I hope it also illustrates the diversity of the roles that are available to cancer nurses. So in relation to that, I'd really encourage everybody to keep their eye out for opportunities. Put your hand up if you wanted to try new things, or let your manager know that you're interested in developing and expanding your skill set and expanding your practice. I was fortunate enough to be given the opportunity to do a PhD, which I took, and I did it with mixed feelings. And looking back now, I sort of think, gosh, that was an interesting experience. And, I'm not like somebody like Priscilla who's continuing on in that area, but for me, I decided clinical practice was where my skill set lay. But I still utilize all those skills every day that I learned to do in that process. And I just want to remind you that there's such a wealth of knowledge in this building for everybody to reach out for. People like Mary Duffy, Trish Joyce, Michael Collins, Priscilla Gates, Yvonne Panic-Hudson. So many people. I would really encourage you to reach out to them and ask them about their views or their experience and what they've done. There's also other people like Kyra and Andy, if you decide that management is the pathway, or Navini pathways that you want to go down. Good luck with that, but they're there. I was very fortunate that when in my early days, I was guided by people like Sancha Aranda and Patsy Yates, and then more recently, Mai Krishnasamy, who's also a dear friend. The other thing I want to talk about is that cancer nursing exposes you to different people and different experiences. Some can be interesting and some can also be an absolute privilege. I wasn't a cancer nurse at the time, but back in the day at St Vincent's, I worked in the prisoner ward called St Augustine's, and it was up on the top floor, and it's security guards from the prison, etc. I was a fairly young nurse at that point, younger than I am now, and naive looking back. Anyway, I was looking after this young man who was very polite, we'd never found out why they were in jail, didn't want to know. But anyway, he was grateful for everything we did. And it came up that, I'd moved into a new rental house, didn't tell him where. And he said, have you got furniture? I said, oh, I'm getting it together, you know, just slowly, bits and pieces. He said, don't worry, love, I'll help you. He said, you know, Patterson's, a store down in Sydney Road, go and have a look on the weekend and come back and tell me what you like. But just make sure it's not too far down the back because it takes too long to get in and out. So lovely. So I was sort of like, once it twigged what he was actually talking about, it was sort of like, oh, thanks, it's okay, I'll be right. But then to the other extreme, you know, I will never forget an experience looking after a man on the haematology ward who I knew him and his family very well. He was dying and I was washing him in his bed and I was even using a bowl of hot, warm, soapy water and a face washer. Woo-hoo. And that was a good thing to do. Anyway, Martin was sort of responding, but then all of a sudden he opened his eyes. And you know, when you say people sat up, he literally sat up and said, Uncle Ray, I can see Uncle Ray. And I thought, okay, you know, who's Uncle Ray? Anyway, we lay back down, we finished. His wife came in and I said, Charlotte, who's Uncle Ray? And she burst into tears. And she said, it was Martin's favourite uncle who died 2 years ago. And when I told her that story that he said, I can see Uncle Ray, that brought her so much comfort. And that's a privileged situation to be in. And that's, you know, that is my next point, that I do see cancer nursing as a privilege and others have felt the same. You know, we share the best of times with people, clear scans, you know, good results, but we also share the worst of times for people when treatment options have run out or we know that there's nothing more that we can do. But it's also a privilege to be able to form relationships with these people and their families. We had the fortunate experience, fortunate, but also sad experience of a young woman who we'd looked after, 32, for many, many years. And she died not that long ago. But we had this, all of our team, the medical oncologist, myself and Alethea had this great relationship with her. We were able to facilitate her getting to a Carlton Football Club training session because that was one of her things on her wish list, that she wanted to go into the rooms. Fabulous. And she sent me throughout the day, she sent me all these photos of her and her husband and her 2 children with all the Carlton players, sitting with them and having lunch. You know, that's a wonderful thing to have been able to help somebody achieve when it was so important to them. And you don't get those opportunities in many other jobs. Dusty Martin was talking recently. I'm not a Richmond supporter, but Dusty, I do admire him. I like him. I think he's a very good football player. And he was talking about being in the Richmond Brotherhood. And that sort of rang true to me when I'm thinking about being in the nursing personhood. Once upon a time, I would have said sisterhood, but personhood and the shared experiences that we have together. We can talk about topics with our nursing friends that you would never talk about with anybody else. I won't embarrass my friend who I was at a exercise class with this morning, and we talked about, you know, particular bodily function. But, you know, you don't talk about your friends about your poos and wees when you go out for dinner, unless they're nurses, or when you go to Keyser. We understand each other. We support and we look out for one another. And it's amazing the sort of problem solving that can be done during a lift home with somebody or a walk down to Melbourne Central Station. You know, we can solve the problems of the world, and we share the load. We share that emotional, that physical load with each other. And I think that personhood of nursing, and again, that more intense personhood of cancer nursing, is something that I treasure and I think is just key to what we do. And I think that care for one another is particularly relevant this week, given the sadness that our urology colleagues and those around them have gone through. You know, if that's not a reminder of being, you know, the need to be there for one another, I don't know what is. So finally, I just want to say I went into nursing because I valued connections with others. And I saw cancer nursing as an opportunity to develop connections with patients, with other colleagues, in a way that was meaningful for me. So I'm hoping that today may be a good day for you to reflect on why you became a cancer nurse. Are you achieving all that you hope to? And if you are achieving that, that's great, keep it up, but keep thinking about what's next. You don't have to stay in one area for your whole career. And if you're not achieving what you wanted to do something to change. Look at those opportunities that are around you. In my view, cancer nursing is a rewarding profession with so many opportunities. But one thing I would ask, so it remains rewarding and so we continue to provide the best cancer care that we can, is please never lose sight of the humans that you're caring for. Don't let nursing be all about numbers or about ticking boxes, because that's not fair to our patients and it's not fair to us as cancer nurses. Thank you.
Thank you, Donna. That's fantastic. So you've heard today of 5 examples of cancer nursing. So just to summarize, Melanie, SCIG, the cancer nurse's role in improving patient care. Joey, the passion for cancer nursing and the choice of cancer nursing as a career, correct one. Priscilla, cancer-related cognitive impairment and the critical role of a cancer nurse as a clinician researcher. Angela, carer-led hydration in the home and the cancer nurses driving the patient and carer-centered care. And Donna, reflections and the advancement of cancer treatment, cancer nursing care and in practice. So again, if we just have a round of applause for everybody. So that's a small example, but a really, really powerful example. We've also got some examples here of more cancer nurses and their contributions at Peter Mac. So please feel free to take one. If I could get the speakers to all come up to the front as well, please, for one more moment. And we just want to give you a little gift just to say thank you very much for getting up and speaking today. And yes, please, it is self-administration. We would like you to just hang for a moment so we can take a photo outside. And one other gift, Kyra. And today wouldn't have happened if we didn't have Kyra helping us and getting everything sorted. So again, thank you to Kyra as well. So thanks again, everybody. Okay, have a lovely afternoon.
Don't hide this.
Yeah, I'll pop in and see you now that I know that you're there. Yeah. Pardon? Yeah, I've got to go up first. I'm going to wash off the way. Yeah, we're going to the pub. Oh, good on you. Yeah. Oh, how long has it gone? Oh, she's good. Yeah, she's great.
I'll grab my laptop.
Are you recorded? Yes, please. So you know, I have the
Oh, how do we stop this?
report. I think
Yes.
Shelley Farah.
Yeah.
So this is